probably systolic function. Let's get started. So, let's go. All right. So, what we're going to get into is we're going to talk a little bit about quantitative versus qualitative assessments of the left ventricular systolic function. I think what we do mostly in the ICU is probably more qualitative, right? So we usually communicate it has good squeeze or not, which is may not be the best way to communicate LV function, but it gets the good job done. I'll talk a little bit about the quantitative part because when you take the boards, you'll have to know these things as far as just getting the answer right. And it's helpful at bedside as well when you have an incomplete picture. The more scales you have, the more things you can get from the incomplete picture. So I'll talk about various methods to assess systolic function. So the methods we're going to use as far as systolic function, we'll talk about linear measurements, 2D, and then volumetric measurements. We'll do the EF. I won't go into LVOT, VTI, or stroke volume calculation or cardiac output calculation. It'll come a little bit later once we have a little bit more familiarity with Doppler. So this is Dr. Bartok's slide. Let's laugh at it. These are three people, those who are good at math and those who aren't. So let's start with Epoint septal separation. So last year, Epoint septal separation is probably from the 70s, one of the original methods for systolic function. And last year we had a fellow, Taryn, who would always do Epoint septal separation, and I kept telling him to stop trying to bring E-septal separation back. It's a nice method, but it can mislead you. But it's a nice method. It's in the context of everything else, right? So Epoint septal separation uses Mmode. You guys have talked about Mmode already, right? Everyone got an Mmode. So it uses Mmode. So basically, what you're saying is, I just care what's happening in one section of the frame rate, right? So it increases your temporal resolution. So you see over here on the right, your Mmode is set right over the mitral valve. And so the computer, the echo machine, is just going to do the evaluation just down that one linear line. And what you're looking for is how close does the mitral valve get to the septum, right, to the anterior septum. Now, stands to reason, if you have a dilated cardiomyopathy, your mitral valve's not moving much, you're going to have a large E' septal separation, right? So that could be indicative of a low cardiac output, low ejection fraction, low stroke volume situation, right? So examples of normal versus abnormal. So let's do a quick review of Mmode because you won't understand this unless you understand the Mmode of it. So we have our line for the Mmode down in the parasternal long view. So it's going over the mitral valve. What do you guys think about this image, by the way? Is it optimized?
No. Context would say no.
Okay, yeah, so reason why I'm asking you, right? So that's good test taking. So it's not optimized in the sense that, look at the angle going up for the ventricle, right? What should it look like? It should be as horizontal as possible, right? And so it's angling up like that. Now, the more it's angled up like that, it's probably an off view, like oblong, like oblique cut. So the more inaccurate your ejection fraction measurements, the more inaccurate your E' septal separation measurements will be. How do you optimize this image? Hirsch did some hand movements.
Yeah. Tilt down.
Yeah, that could be one. The one that
go up or down over.
Exactly. So the test question answer is going to be, if you can go up a rib space, go up a rib space. Right. So the personal law. So that'll be your test, and this will be asked on the boards. And so that's one part I wanted to mention. So looking through the Mmode, so the Mmode actually parallels the Doppler as well. So just like on Doppler over the mitral valve, we have our E wave and we have our A wave, right? And so essentially what's happening is, so you want to correlate with your EKG. You have your QRS, and you know systole is happening right after, right? So you have systole right here. And then around, right after your T wave, diastole is going to start. So in diastole, your mitral valve is opening, So the E wave is reflective of the motion of the mitral valve during the initial passive outflow. So the second your left atrial filling pressures rise above your left ventricular filling pressures, your mitral valve will open, and this valve will open up as well. So this is what a normal E wave will look like. In between, you have what's called diastasis, and then you have your A wave, which is your atrial kick. Your atrial kick, if you wanted to draw a line, you can find probably right after your P wave. It's always important to correlate what your on the test. It's going to be really important to correlate all of your findings with the EKG because it'll help you figure out what phase of the cycle is, and you can often answer the question correctly through that. Now, this is a normal one. So you can see there's not much of a difference as far as where the septum is and where the mitral valve is opening up. So the Epoint septal separation is tiny. On the other hand, down here on the second one, you can see that there's a large E-point septal separation. There's 29 millimeters, right? So this is indicative of likely poor systolic function. The mitral valve looks like it's barely opening, and we've all seen poor functioning valves. One of the indirect things that you always get taught is if you can't see the walls very well, try to look at the mitral valve. If the mitral valve is slapping the septum, the left ventricular function is probably okay. Sorry, guys, transfer.
What about like mitral stenosis?
Yeah, hey, Daniel. Hold on 1 second. Hi, Jason. Sorry, do you guys have a question?
Okay. I was just wondering about like mitral stenosis.
Mm-hmm. Yeah, what do you think would happen?
You'd also have a large.
Beautiful.
SS.
Yeah. So that's one of the things that may cause a falsely reduced E prime septal separation. Why do you think that is?
You don't have full movement of the
Yeah.
anterior leaf.
Yeah, so it's calcified, and depending on what the mechanism of the mitral stenosis is, it'll look different. But what do you think how would this look different in mitral stenosis? So you have, let's say you have that distance. So you have the distance there. Now you're saying, is this mitral stenosis or is this reduced systolic function? What do you see? What would you see here on the actual leaflets? It's probably thickened and calcified.
Oh.
Yeah, so this will look a lot thicker, and you'll see both on the Mmode and also on the actual 2D image itself. So that'll be your signs that this is more mitral stenosis than left ventricular. And then you can also look to see about the volumes, right? So you look at the end-systolic and diastolic volumes. Is this a dilated LV or not? Right. So that is another sign. Is this mitral stenosis related or left ventricular dysfunction? Right. So these are some signs, and that's an excellent observation. Yeah. So you'll have to differentiate between mitral stenosis and poor left ventricular function, but those are some key finding differences. So video, and again, right, so the upsloping left ventricle, which sometimes is the best you're going to get, right? Sometimes it's the best you're going to get. So you can use it, you can try to reason through it, but always take it with a grain of salt when it's not a perfect image. I feel like I rarely get perfect images on our patients, right? You can't position them, and so you just go at what you have. So on this one, the Mmode is coming down again, right? So you have your right ventricle, you have your septum right here, and then coming down, it's going to be your left ventricular cavity, and this is your mitral valve motion, right? And so find your EKG, and you try to figure out where is systole. So I have my QRS here. I know my systole is going to be happening around here, right? And so this is diastole. And so this is where my E and A waves are going to be, right? So on this one, look at the size of this LV. What do you guys think? It's not moving, it's a still, but just looking at it, right? Just looking at it, it just looks large, right? So if you actually measured the left ventricular proportions on this, you would probably have large left ventricular and diastolic diameter, and left ventricular and systolic diameter as well, right? So this one, what do you think the reason for the large E prime septal separation is? Is it mitral stenosis or is it left ventricular dysfunction? Probably left ventricular dysfunction, right? All right, so let's do a case. 56-year-old male is admitted to the ICU, respiratory distress, 2+ pitting edema, increased pulmonary vascular resistance, vascular congestion on X-ray. We calculate a E prime septal separation of 24 millimeters. So when she measured this is 24 millimeters. Which of the following findings will allow for EPSS to be a useful surrogate for left ventricular function? C? Okay. Why not? So C is the correct answer. We already talked about mitral stenosis. Why not?
So in the setting of aortic regurgitation, if your regurgitant jet is directed back at the mitral valve, then during diastole, when the mitral valve is open, that regurgitant jet will keep the mitral valve from opening completely. That's why sometimes you get osteopenia in the setting of aortic regurgitation.
Now put it into, it's less a physical push. Put it in terms of pressure.
Sure.
To put it in terms of pressure in the left ventricle versus the left atrium.
Sure. So then in portions of diastole, when the left atrial pressure is supposed to be greater than the left ventricular pressure, you're going to have the inverse happen. The left ventricular pressure is going to be greater. Because that left ventricular pressure is greater than the left atrial pressure, it's going to cause the mitral valve to close up.
Yep.
And so you're going to have increased separation between the mitral valve leaflet and the septum.
Good, beautiful. So the left ventricular diastolic pressure is higher than what you would expect it to be, right? And like you said, the left atrial, the pressure difference where the mitral valve should open, it's later or it may not happen at all. So what would you, when you say Austin Flint murmur, what would you see on the echo? What would you see on the echo?
So it mimics physiologically mitral stenosis.
Okay, so it may, but the valves wouldn't be thickened, right?
Correct.
So what is the actual phenomenon that causes that murmur? The fluttering is part of it, and then you also get diastolic mitral regurgitation, right? So you're getting diastolic mitral regurgitation is pathology, right? It's a significant pathology. And if you see that, so it takes what you're saying, Hirsch, and it takes it to the extreme level. The pressure in the LV is so high compared to left atrium, you're getting diastolic mitral regurgitation, because mitral regurgitation is a systolic process, right? So that's the physiology of it. So aortic regurgitation makes this difficult to interpret, right? And then segmental wall motion abnormalities, again, that's just the dysynchrony of it. And so you may see different things at different phases of the cycle, right? So these are the mechanisms of why EPSS might not be as helpful in that situation. Okay, linear assessments. So linear assessments, so your fractional shortening. So fractional shortening is interesting, but you have to keep in mind, it's kind of like your chest X-ray or your chest CT, right? It's your 2D linear imaging, and the heart is a 3D structure, right? So there's a lot of limitations, a lot of geometric assumptions you're making. So for fractional shortening, it's relatively simple to do, and the cutoffs are going to be normal is greater than 25% and severely reduces less than 14%. So the way fractional excretions, I'm thinking about nephrology. Fractional shortening is calculated is so you can have it in Mmode or you can have it in the 2D, but you're basically taking the difference between your left ventricular end diastolic volume and your left ventricular end systolic diameter, not volume, sorry, diameter. So the difference between those two divided by the bigger number, which is your left ventricular end diastolic volume, diameter times 100. That's your fractional shortening percentage, right? And so this is just a nice, simple way for us to look at, and we're doing this intuitively as well as when we're doing qualitative assessments of the echo. We're basically noticing is it coming together or not. During systole, are the walls coming together, and that's kind of intuitively you're doing your fractional shortening there. It's nice because it's easy to do, but you make a lot of geometric assumptions. You can also do it in the parasternal short axis, right? So you just put the line down in the middle, and then the Mmode. I usually do my measurements in Mmode. Make sure you exclude the papillary muscles, right? So let's say you did it like this, right? Or you did it like this. like right here in the papillary muscle, you're going to get different values. So make sure you exclude that and you try to put your line down here in the center for in this personal short axis. Mepsi. How many of you guys have used Mepsi before? Yeah, it's good. Yeah, it's Mepsi is making a comeback actually. So Mepsi is, for those of you who already know what TAPSI is, it's the left ventricular cousin. And so in systole, you basically put an Mmode down into the mitral annulus, and you're basically looking for longitudinal motion up and down of the mitral annulus. And so I'll show you guys an example. And then for men and women, the cutoffs are a little different. Men, it's greater than 11 millimeters, and women, it's greater than 13 millimeters. So this can correlate well with systolic function. And so your Mmode will go down this line. And this is a surrogate and similar to what we would do for tissue Doppler, right? And so this is Mmode, and an Mmode is literally measuring the distance, the excursion up and down. Tissue Doppler is if I'm putting my tissue Doppler here or tissue Doppler here, I'm telling the ultrasound machine, I don't care about the velocities of the blood, I care about the velocities of the tissue, and then you're measuring the velocity up and down, not distance. But they tell you the exact same thing. So just like the distance of your Mepsi greater than 13 in women is going to be equivalent to a greater than 9 centimeters per second on tissue Doppler. So velocity and distance can both be used to assess systolic function for the left ventricle. And again, none of these tests should be done in isolation, right? We're trying to integrate the whole picture. If you have 4 things saying one thing and one is an outlier, then let's take the 4 things, and it's probably leaning more towards those findings, right? So this is an example. So you have your Mmode coming down, your mitral valve. So you have your medial mitral valve annulus, you have your lateral mitral valve annulus. You measure your Mmode, and then just like you would do a TAPSI, you would measure this across. And so that is going to be indicative of your systolic function. Again, men is greater than 11, women greater than 13. And then TAPSI, we may not have talked about yet. We're again just going down your RV free wall, right? And then you can also do the same thing with tissue Doppler there, and you measure your velocities and distance from over there as well. Linear assessments, they're easy, they're quick, but they also, like I said, make a lot of assumptions. So use them with a grain of salt. Now, I think most of you guys as second years, you're good enough as far as like qualitative assessments. You're good enough as far as Doppler measurements and cardiac output measurements that where you may not need these linear movements anymore. Right? So that's where you'll eventually get. So fractional area of change. So fractional area of change, the volume, it's not volumetric, it's more area based, right? So you're going from 1D now to 2D, and eventually you want to get to 3D, right? This is a area based calculation. The measurements are going to be 35 to 65% range, and I'll show you guys examples of this. So the fractional area of change is calculated pretty much the same way that you're doing the last measurement, but this is going to be more area based. So you have your 2 cycles, you know during diastole, it's going to be larger than systole, and so you would freeze this whole frame, and then you would measure the largest diameter during diastole, your largest diameter during systole, and you would just do, the measurements are simple after that. So your end diastolic area minus your end systolic area divided by your end diastolic area times 100. And that's your fractional area of change, right? As we're moving up, we're doing slightly more advanced things that require a little bit more finesse and ability to do these measurements, but they also start to get more and more accurate towards actually telling what the left ventricular function is like. So in this situation, it's 24 centimeters squared, 15 centimeters, and 24 minus 15 divided by 24, we have 37.5% fractional area of change. Simpsons Biplane method is probably the method that's most used, and it's like for echo techs, for echo labs around the world. This is the method that they use for assessing volume. So essentially what Simpsons does is you trace. So as the sonographer and as the person you're getting the measurements and capturing the images, your job is you actually trace around the LV. And what the machine does is that it makes the assumption of disks. So a bunch of tiny disks. And so you're basically measuring the volume of a disk all the way down. And then it sums it up together. This gives you a more 3D volumetric approach to ejection fraction. Hence, it's more accurate compared to a fractional area of change. So Simpsons Biplane, you don't need to understand too many nuances of this, but literally it takes the area of 20 small cylinders and will add all of them up. When you're doing it in real time, if you're doing it with a sonographer, you get it with both the 4-chamber and the 2-chamber as well. Right, so you look for agreements between those two as far as the ejection fraction calculus. Right? And then ejection fraction, we all know about, we use that word on a daily basis. It's good, it's helpful, but also has its flaws, which we'll talk about. So, sorry, go ahead.
So quick question, if you were to describe, I guess, the relationship between Simpsons method compared to the fractional area change, essentially fractional area change is like Simpsons method, but you're just looking at one disk alone.
Yep, exactly. Okay. So one cut alone, and it's usually done in the peristernal short axis. And the peristernal short doesn't give you that full volume of that LV, right? So this is why you do it in your 4-chamber and your 2-chamber. And so the 4-chamber cutting it like this, the 2-chamber is cutting it like this. Yeah. Now you have a 3D view of that. So
this is the LV, the Simpsons is like this. And then if I switch over to do the fractional area of change, I'm looking at it from up top, and I'm just taking one single disc.
One sliver, exactly. Right. So you can say of the instead of 20, you're getting one disc. That's the perfect way to say it. Okay. And so contrast can be really helpful. So a lot of our echoes look like this, right? It's kind of hard to say what the function is. We think it looks a certain way. You add contrast. Now you can see the LV borders so beautifully, right? You can see the LV borders so beautifully, and you may have a completely different ejection fraction assessment after you've done contrast, right? So we've actually had the Definity reps come to us and talk to us, but we haven't really made this a regular thing, but obviously you've seen sonographers do this, and the echo labs do this pretty consistently. Pros for biplane, this is the most used method in the world. This is what we've agreed on. This is our common language, and it's volume-based. Cons, it takes a little time, and it actually takes practice, right? So you have to be able to get the 4-chamber and the 2-chamber. Make sure you're doing your tracing correctly. And so there's a lot of things that you have to learn over time, and it takes a little, and actually, absolute time at the bedside, it also takes longer. Our mind rays have an auto EF feature. And so basically you would get your 4-chamber or 2-chamber view. You would trace. Hey Jason, is that Nadine?
Is that Nadine Bark?
Might be, yeah.
Can we talk to her?
Yeah, if you don't mind.
Absolutely. Hey Sharad, so hi Jason, what about? Hey Jason, Sharad's here.
All right. So Simpsons Biplane. Yeah, so this is the one that we're going to be using most often. The auto EF method on the mind ray is actually pretty nice. You just have to trace the left ventricular borders, and you have to adjust it. So you can do your initial, it'll try to trace it first. It'll trace it on its own, and then you just make adjustments, and then you press play, and it'll give you an auto EF on that. So it's pretty cool feature. So qualitative assessment, this is what we mostly do. In the ICU, I don't care if the function is 55% versus 60%. I don't care if it's 35% or 40%. For us, it's more qualitative, and we're going to take this information and we're going to basically break it down into kind of like just bins, right? Hyperdynamic, normal, mild, moderate, and even beyond that, we might just say hyperdynamic, normal in 1, mild, moderate, and then severely decreased, right? So you can even make it even simpler than that. But these are your language. This is your language for qualitative assessment. What do you guys think about this, LV? Okay, yeah, most likely, right? And so you're seeing the mitral valve that's actually getting close to the septum. Left ventricular walls, like if I have my finger here, it looks like it's coming in nicely, right? So normal EF. And so one thing, if I did M mode over here, what would my E prime septal separation be? If I put my M mode down here. High or low? Brian?
Low.
Low. Good.
Can I ask you about that
Yeah.
view? Sorry, I'm always confused by this. What could you draw the outlines of the actual left ventricular chamber?
Yeah. Sure, like, the next one would probably be easier. So,
This one I can see a little better, but
oh, okay. So just particularly on that one?
yeah,
Let's see.
because there's all that. What's it called?
The noise over here?
Yeah, right.
Yeah.
That's
So,
probably nice.
and so my, here, what you're probably seeing is just like the connections of the mitral valve, right? Papillary muscles coming off. So my drawing would be going, so as it's coming in right here, right? I wouldn't be including the papillary muscles there. Okay. What about this one? I can buy that. Yeah, I can buy that. I'll never mess with you on moderate versus severe. Just I can buy that this is moderately reduced, right? Good. So you have diminished endocardial excursion. If you did E prime septal separation, there would probably be significant difference between distance between your anterior mitral valve and the left ventricle. Yep, and so those are the major things. This one is probably severe, right? So now you see how like.
Actually, I think it's moderate.
He's not gonna argue with you.
I won't argue with you on that, man. So this is barely opening, right? And so, and this is where, Brian, to your question before, mitral stenosis, there's no question. Look at this LV, it's big, dilated, mitral valves opening, and you'll train your eyes, but it doesn't look like it's thick and calcified or anything like that, right? Now here can be misleading. It's hard for me to draw where the left ventricle fully is, right? It's off axis. So it's hard for me to assess. Now, the mitral valve looks like it's getting close to the septum. Now, indirectly, I might be able to say it's okay, but it's hard for me to say what the function really is there. But if I had to guess, just with the overall movement, then it's probably going to be okay. Anything major?
Everything's good. I'll let you know.
Okay, perfect. All right. What do you guys think here? Yeah, so in the peristomal short axis, the way I was told is that you're putting your finger here in the middle, and it looks like is your finger going to get cut off or not. My finger will get chopped off here, right? So it looks like the walls are coming in really nicely. It's completely obliterating the left ventricular cavity. So most likely hyperdynamic left ventricular function. Does this mean that they're dry? This is what I always see the assumption made. Left ventricular is hyperdynamic, therefore it's dry. But here, I'm trying to see is the chicken or the egg. Is the left ventricular function hyperdynamic due to some primary cause that led to adrenergic drive, increased endogenous epinephrine, causing a hyperdynamic appearance, and leading you to think that they're hypovolemic, right? This left ventricle, if the right ventricle is the same, what do you think the IVC will look like? It's going to collapse because your pump is so efficient here of pumping out everything that's coming into the IVC. Your right atrial pressure is going to drop immediately. Your right atrial pressure is dropping immediately, your IVC will collapse. Cannot say that they're dry, right? Don't jump to that conclusion that they're dry because you see hyperdynamic LV and a collapsing IVC. What you can say is that they're probably tolerant to fluid. This left ventricle, that IVC can take whatever you can throw at them, right? So it's probably tolerant to fluid. Does that mean that they're dry? Right? What about this one? Sucks, right? It's poor left ventricular function. What view is this, Brian?
Short axis.
Okay. So peristome short axis.
Short axis, yeah.
Yep, good. So the peristome short axis, but if I were to put my finger here in the middle, it doesn't look like it's getting anywhere near that. Is it global dysfunction? Or do you think there's certain walls not coming in well? And it's tough, honestly, I'll tell you. This is something that I had a hard time getting when I first started doing ultrasound, is looking for wall motions. And so what I was taught is like I put my finger here in the middle and literally I focus my attention on this vascular distribution. And then I go straight to this vascular distribution. And then I go to this vascular. So I'm going and I'm focusing on small parts of the left ventricle and I'm seeing how does that part look. If you try to look at the whole thing at once, oftentimes you'll miss wall motions, right? And so this is one of the strategies that I was taught, is to look at specific areas within the left ventricle itself. All right, so let's try to get through this. How are we on time, Jason? Okay, perfect. So left ventricle function severely reduced, right? So again, you put your finger here in the middle. It doesn't look like it's coming in well. Now, what do you guys think about the wall motions here? Good, yeah, right? And so the interseptal, right? So interseptal, maybe even intralateral here. So interseptal, intralateral. So what distribution is that? LAD. So it's LAD. So this is going to be getting more advanced as you go, but over time, you're going to start looking, because we have EKG abnormalities all the time, right? How many EKGs do you look at that are actually normal in the ICU? Now, if you feel like there's ACS going on, pick up the probe, get a peristernal short axis. You can probably be able to say, are there focal abnormalities here that match what I'm seeing on the EKG, right? Then you can just take it to another level and seeing if there's actual ACS happening here or not. What do you guys think? So the key over here is that when you see kind of like a lot of movement and then it's like obliteration of the left ventricle, it make you see, so depending on where you are, if you're really down low in the apex, you might be able to think that this is a hyperdynamic function. And this may be, is just make sure you confirm higher up and maybe at the papillary levels to make sure that this is also what you see if you see obliteration of the left ventricle or not. Yeah, I'm trying to get the Doppler, so let's go through some of these a little faster. All right, what do you guys think?
Reduced.
Moderately reduced.
Everything's
Moderately reduced. Yeah, so it looks like it's moderate to severe reduction in left ventricular function, right? So if you have someone who's hypotensive, you see this may be a cause of that. And this isn't a talk about ACS, stress tests, and things like that, so we won't focus too much on the walls. Right now, we're really just looking at trying to figure out what the skill of looking at left ventricle and assessing systolic function. Now, left ventricle here looks pretty obvious, so it's hyperdynamic. What do you guys think about the RV? Because I haven't mentioned the RV yet. Yeah, right? So how are you basing that visually?
Size.
So size looks okay. So the pretest that it's going function is going to be good is probably good, right? What else? Look how much it's going up and down, right? So the subcostal is probably not the best image to get this in. You're going to get a 4-chamber, but what a TAPSE is it tells you how much distance this is moving up and down longitudinally, right? And the tissue Doppler is just measuring the velocity of how much is going up and down. So our surrogate for right ventricular function is not me putting my finger here in the middle, is actually the longitudinal function. right? So that's how I tell about it, and it correlates well with RV systolic ejection fraction. What do you guys think? Is the RV poor function? It's kind of going crazy. Yeah, it's going, well, that's, if when one ventricle is not doing well, the other ventricle will usually compensate, right? You've seen PE, RV failure, and this is acute PE in an average person, what is the LV doing? It's going crazy, right? And if you were to do measurements within the LV, it looks almost hypovolemic, hyperdynamic, but it's all because it's compensating for the right ventricular function. Here, the left ventricular function is not great, and the right ventricle is trying to compensate for that. So if you were to measure it, and that some might say, is this diastolic collapse? I'd be hesitant to say that. I'd be looking at other views, because when it's super hyperdynamic like this, it may look like there's diastolic collapse, but it's actually just how hyperdynamic that RV is. So this TAPSE would probably be pretty high, and the tissue Doppler would probably be pretty high, but I wouldn't do it in this view because your angle isn't perfect, right? You want it straight. When you're doing tissue Doppler or Mmode, you want to try to have a straight line down. So same thing, also reduce left ventricular function. So the things we kind of covered here is the approach. Quantitatively, we talked about fractional area shortening, fractional area change, and Simpsons Biplane. Mepsi, Epoint separation, really nice, quick things you can look at, but you probably already, over time, you'll just intuitively look at it and just try to and be able to figure out what the function is. In the same way, when the alternative to Mepsi again is the tissue Doppler for the mitral valve. So a tissue Doppler greater than 9 velocity for the mitral valve is consistent with a normal ejection fraction as well. And then qualitatively, this is what we mostly do. We eyeball it, right? So the evidence shows is that just the more experience you have, the more, most people can tell the extremes, but the more experience you have, you're less variability you're going to have in the middle. The moderate versus, like the 35% versus the 45, 50%, right? So the variation gets smaller and smaller in the middle as you become more experienced. But for us, again, we want to put them into bins, and that's all we really need to do. And I want to show this case. So really, one of my biggest, not pet peeves, but just kind of like my crusade is against ejection fraction and the assumption that you cannot have cardiogenic shock when you have normal ejection fraction. That is absolutely not true. Right, it's absolutely not true. So let's take these two left ventricles, these two left ventricles in parasternal short axis, right? Let's say this ventricle right here, do you think this one has a large end diastolic volume or a small end diastolic volume?
Large.
Large, right? And so EF is your stroke volume over your end diastolic volume, right? So if this is 200 and this is 48, my EF is pretty low, right? This is close to 25-30%, so I have a low EF. Now, let's go over here. Do you think this end diastolic volume is small or large? Small. So let's make this end diastolic volume 75. So you put 48 over 75 over here, EF's through the roof, right? But the stroke volumes are exactly the same. Just let that sink in for a second and think about all the times we've signed out EF is normal, and with that assumption comes that the LV is fine and they're unlikely to be in cardiogenic shock, right? And you're going to learn a lot more about this later on as we talk about diastology and other mechanisms that where the left ventricle, you can be in cardiogenic shock, but it doesn't have to be systolic dysfunction. Cool? Questions on that? So Doppler. So this is an hour lecture on its own. So this is an introduction to Doppler, which is my favorite. So Doppler is the method that we use to do a lot of our hemodynamic calculations, through which we differentiate a lot of our shock, right? As I mentioned, EF has its limitations. You really need to get to the nitty-gritty of Doppler to get true hemodynamic differentiation. So the four types of Dopplers that we'll be talking about is pulse wave, continuous wave, color, and tissue Doppler. We probably will only have time to talk about pulse wave and continuous wave, but we'll talk about the principles of that. Color can be difficult, so I will probably hold off on really focusing on color today. And the tissue Doppler is relatively simple. If we have time, we'll talk about that today as well, okay? So, Doppler principles. So, remember in physics, is that if you have a moving object, if you're stationary, the frequency perceived will be the same all around, right? F1 will be equal to F2. As soon as you start moving, the structure that you're moving towards will have a higher frequency than the structure that you're moving away from, right? And this is called Doppler shift. You can take advantage of that, is that if you can measure the Doppler shift, then you can inversely go back and calculate velocity as well, right? So you can take these physics principles and go backwards, and you can get velocity, is what we're interested in, right? So we're trying to, what we started doing is we started measuring the velocity of the red blood cells, right? So this is what we're interested in. And so this is the Doppler principle. Now, this is the equation for Doppler shift. Now, it can look intimidating, but the only things you really need to know for the Doppler shift is know that it's your initial frequency. These are constants, but it's your angle, right? So cosine here. So I will tell you is that when this angle is 90 degrees, this value is equal to 0, right? And so the closer you get to parallel or 0 degrees, if your object of interest is moving in this direction, you better have your pulse wave going down, continuous wave going down in the exact same angle, right? Closer you get to that 0 degrees, the more accurate you're going to get as far as the calculation. But this is the key for us, is the cosine is the angle.
Can you adjust that on the ultrasound?
The angle?
Yeah.
Yeah, with your probe?
Yeah.
No, I mean, if you can't move, if you can't optimize.
Oh, you mean the angle adjustment? Yeah.
Can you like
Yeah.
set that angle?
Mhm.
You can, but
Mhm.
it'll only work well up to a certain point.
Mhm.
Like, once you go past like 20, 30 degrees or so, interpretation gets unreliable.
So, yeah, there's an option on there. Most of the time, you can get the correct angle, at least close to the correct angle, right? So it's just learning the fine finesse movements over time will help you get as close to 0 degrees, and then you can use that as an adjunct. It's an example of why the angle is important, right? So this is, we took the Doppler shift equation, and then we did some algebra, and then we can get the velocity of the blood move, right? So this is my probe. So and this is this is my probe, and this is my peristernal lung. I'm trying to get an angle as close to, so in the four-chamber here, if this is your four-chamber, you have the left ventricle, right ventricle, and you have your aortic outflow tract here, right? The cardiac output calculations are going to be from your aortic outflow tract. My angle of my aortic outflow tract is going this way, right? But my probe may be going down this way. So you see the angle difference? So your Doppler measurements will be slightly inaccurate. And that's okay. It's okay if that's the best angle you get. Just know that when you're measuring, you're probably going to be slightly underestimated, right? That's the thing about ultrasound is that the more experience you get, the quicker you'll realize the things that you should take with a grain of salt and the things that you probably shouldn't even take in as information at all, right? Most of the time you can get some information, but if you have a poor angle, you just know that you're just probably markedly underestimated as far as the velocity measurements. And you can tell on the Doppler waveform. So over time you'll be able to tell the Doppler waveform is this a big signal or not. And again, the importance of angle. So just getting past 20 degrees, your error, look how much exponential increase in the error is as your angle gets worse. As far as flow, so the difference between, so there's a reason why we use pulse wave and continuous wave, right? So actually, let me go on to the next slide, because that slide will be more obvious once we understand the difference between the two. So in pulse wave, you have your probe, it's sending a pulse one at a time, and it's waiting for the pulse to return, right? So it sends, receives, sends, receives. And so this is pulse wave Doppler. The frequency of these emissions is important.
Marie, you have a call on line
The
2.
distance
Marie,
between your probe
line 2.
and the object of interest is important, right? So this is going to be, this will really dictate how good your signal is and a lot of the important phenomena you have for Doppler measurements. So pulse wave Doppler, what's the difference? So pulse wave Doppler. In pulse wave Doppler, I'm saying is that if my Doppler angle is going down here, we've all seen the little gate, right? So it's a little parallel sign like this. The Doppler gate is placed at the area where you want to measure the velocity. You're telling the machine, I don't care what the velocities are anywhere else. I just want to know what it is right here at the aortic outflow tract. So the measure, basically the actual visual you're going to get of the Doppler measurements will look like this. So here, you're actually over the mitral valve. So you're over the mitral valve, and you're telling them, I just want the measurements over the mitral valve. What you're going to get is you're going to get white on the outside, and then dark in the center. And what that tells you is that there's a flat velocity profile. So all the blood in a small area has the same velocity. So this is why it's all white on the inside. So it's all one flat velocity profile. If there were turbulent flow and a lot of different velocities, this would be colored in, right? And so in pulse wave, it's a really small area. And so the ideal image will be like this, where it's white on the inside, dark in the center, right? The upper limit of the measurements for pulse wave is about 1.5 to 2 meters per second. Exactly because of what I mentioned before, and then I'll talk a little bit about that, is that the pulse wave, you send one signal, you're waiting for the other, and there's a limitation of how high velocity you can check with pulse wave Doppler. Right. And so for the boards, what you really need to understand is the concept of pulse repetition frequency, right? So pulse repetition frequency, it's basically 1 minus time. So the interval between the two transmitted pulses. You sent a pulse, you received, so the time between the two. The time between the two will also depend on the distance itself, right? So this is why you want to minimize the distance between you and your target of structure as well, right? And so the pulse repetition frequency will increase as my time from emitting one frequency versus one pulse versus another decreases, right? That's an important concept. And from the pulse repetition frequency, you're going to get this, what's called Nyquist limit. And basically, the Nyquist limit is your pulse repetition frequency divided by 2. That will determine, can I tell the velocity, the direction of the velocity of this blood? Because when it gets above this velocity, but above this limit, I can't tell what direction blood is going. And this is actually, I struggled with this concept in the way, and this is probably the best explanation that I found. This is from 123 ultrasonography. If you look at this clock, right, you're checking, so every 15 minutes, I'm checking to see what time it is, right? So you see a nice, you know that this one is going clockwise. Now I'm going to reduce the cycle, the number of times that I'm going to be looking at the clock and seeing, we're trying to figure out what direction this is going. This one, I can't tell if this is going clockwise or counterclockwise, right? Here I can tell, here I can't. And so this is analogous to Nyquist limit. Or if you're above the Nyquist limit, which is above, let's say, it's faster than this 1.5 cycle. So if if your Nyquist limit, if you go your velocity, if the blood that you're measuring goes above your Nyquist limit, then you won't be able to tell what direction, and you're going to get a concept that's called aliasing. I'll show you aliasing in a second, right? The difference between pulse wave and continuous is that continuous wave, just like the name, is sending pulses and receiving pulses at the same time, hence continuous. There's no aliasing with continuous wave, right? You can constantly receive and emit, so you don't have any aliasing. You can measure high velocity structures. So when you're measuring things over the aortic valve, doing aortic valve measurements, you're often using continuous wave measurements. I'll end here, but I just wanted to show you guys a picture difference between pulse wave and continuous wave and understand why the appearance looks different, right? I mentioned before, in the pulse wave, you're looking at a really small area, right? And so it's a flat velocity profile. So this is all the red blood cells are moving together in a flat velocity profile. In continuous wave, you see, my line is going all the way down here. I've told the machine, I want to know velocities about all the red blood cells along that line, all of them. And so that just tells you that you can probably imagine the density of the red blood cells is larger. There's more different red blood cells in different locations going in different velocities in different directions, right? And so this is why this is all filled in. These are all indicative of red blood cell velocity. And so there's a lot of variance of red blood cell velocity because it's a larger area. So this is a key difference between the appearance of pulse wave and continuous wave, right? And then the continuous wave, you can get larger and faster velocities and you'll know the direction of this, right? But this is why the appearance of the two differ. Give you an example of aliasing. So here, so we have a mitral signal. We have our E and A, which we'll be going over later on. You don't need to know that right now. But if my velocity goes above my Nyquist limit, this is what you're going to see. The machine has no idea what direction. So there's deflections here, deflections here. The machine has no idea the direction it's going. So this is called aliasing, right? And so later on, you're going to be board questions like, it's aliasing, you're trying to get rid of it, what can you do? Can you reduce the depth, right? So these are the things that you'll learn a little bit later on, and this will be board questions coming up. But this is what aliasing looks like, right? And so we'll stop right there.
So even though that was trying to capture the movement of the mitral valve, you have aliasing of the mitral valve?
So you have aliasing. So this right here is telling you during this cycle, the velocity of that blood is going too fast. And what you might have is mitral regurgitation. So high velocity. So this is so look at your EKG again, right? So you have your QRS, this is systole, right?
Okay.
So I know blood velocity is going really fast during systole.
Oh, this is not an ENA wave of Mmode on the
Nope,
mitral valve.
this is Doppler. So I should have cleared that up. Yep. So this is pulse wave Doppler.
Okay.
Yeah. Right. And we'll stop right there.
Okay.
Right. Questions?
I have a question. When you were mentioning the Doppler shift and the cosine of angle, so ideally you would want it to be less than 20 degrees, but how can you tell what your angle is? Like, how do you know how far you are from the angle of the blood flow? Is it just something you're eyeballing?
Yeah, that's a good question. So, right, so let's see, this is your LVOT outflow tract. What I'm trying to do, so my LVOT outflow tract's angled this way. I am trying to match that best as possible. So I know blood's going to be going in this direction, right? And so my pulse wave will be right here in almost the exact direction the LVOT outflow tract is going, right? So you want to be as parallel. If you have the mitral, if you're worried about the mitral valve, right? So if this is your mitral valve, this is your left atrium, your pulse wave will be right above where the mitral valve is going to be opening and the flow is going to be happening, right? And so this is the angle that you want. So it's about knowing the anatomy and knowing what direction the blood's going and where the valves are, and you want to try to parallel to the opening of the valves.
Okay, so there's no number on the screen that will come up and they'll say like, oh, you're like 40 degrees away, so you should try to readjust yourself. And
you know what? That's a good AI project I'll work on. So there's nothing that exists like that right now.
Okay. All right. Thank you.
Yeah. All right. Thank you guys.
Doppler